So we are going to go live on Zoom and let the people sign in. And also we're going to go live on Facebook. So it's 8 o'clock Amman time. We have a total of 170 attendees registered for the event. So we'll let them sign in. Okay, so we'll start. We'll go ahead and start. This is just a brief introduction. First of all, welcome back again, everybody who's joining us for our Jordan Surgical Ground Rounds. Today we have, we are going to discuss rectal cancer, colorectal session, mainly rectal cancer. I would like to welcome our panelists. We'll start with Dr. Bashar Safar from Johns Hopkins. He's the Chief of Colorectal Surgery and Assistant Professor of Surgery at Johns Hopkins. Thanks, Dr. Bashar, and thanks for Mohammed Arfishat, our Jordanian friends at Hopkins who introduced us to you, and thanks for taking from your busy time on Friday. Dr. Ahmed Ariqat, he's the Chief of Colorectal Surgery Unit at King Hussein Medical City. Dr. Shawqi Bazarbashi, he's Adjunct Professor of College of Medicine at King Faisal and Head of Section Medical Oncology, and I know he has a special interest in rectal cancer. Dr. Isa Muhammad, he's a Consultant Radiation Oncologist at King Hussein Cancer Center. And finally, my friend Shadi Hamdan, he's my classmate. He's a Consultant Hematology Oncology at Advocate Health Group in Illinois, USA. Before we go to our main sessions, I would like to ask our attendees if you would like to continue these sessions in Ramadan, and I would love to hear from you before we make a final decision. So the poll is out there. Can you please answer if you would like to continue such sessions in Ramadan? We know in Jordan we are hitting bad with COVID, and Friday is a complete letdown till the end of Ramadan. So would you love to continue such event in Ramadan or not? Okay, so I see we have around 60 attendees so far. So the majority, 76%, had answered yes for Ramadan. Okay, so we'll do our best to continue such event in Ramadan. The other questions, would you like to continue the same day of the week, or would you like to change it? Saturday, Friday, Thursday are the option. Can you please pick and choose? Again, we have around 60 participants so far. Would love to hear from all of you if possible. So again, still most people, 91% had chosen Friday, okay. And the last question of the time, you know, Ramadan, we would have this time is almost the time of iftar. So would you keep it the same time, 8 p.m., or maybe delay it to be a little later in Amman time? 8, 8:30, 9, 9:30. Can you please pick and choose? I mean, if there's no Taraweeh, there's no prayer because we lockdown start at 7 o'clock. So what time you would like to have it? Okay, so we have the majority, or at least almost 50% had chosen 9:30. So again, we'll do our best to continue. And we're gonna, before we waste any more time, we are going to end this introduction and start our first case of challenging cases. Stop sharing and then share screen. Okay. Okay. So this is the first case of our sessions today. This is a 32-year-old male patient. He's healthy, had complained of blood per rectum with perianal pain, And his colonoscopy had shown a mass, an ulcer, to around 2 to 3 centimeters from the anal verge, as you can see in this retroflexion view of the colonoscopy. And biopsy is actually adenocarcinoma mucinous type. His CT scan was not significant for any metastatic disease. And you can see this is the pelvic component of the CT scan. You can see there is some thickening of the rectum posteriorly right there. And this is his pelvic MRI. As you can see here, there is this T2 hyperintense signaling in the rectum, very close to the external inner sphincter, as you can see right there. You can see these are some sort of like thick mucinous changes in the distal rectum. I hope the images are clear for my panelists and for the attendees. 32-year-old T2, they read it as T2, no lymph nodes, low-lying rectal tumor with almost indirect contact with the external inner sphincter levator E9 muscles. So the question for the poll that we are going to start right now, what would you do for this patient? This is a 32-year-old low-lying T2 mucinous adenocarcinoma. Before for surgery, for surgical resection, neoadjuvant chemotherapy followed by surgery, neoadjuvant chemoradiotherapy long course followed by surgery, neoadjuvant short course radiation therapy followed by surgery, or total neoadjuvant treatment, chemotherapy plus radiation therapy followed by surgery. This is actually back in 2018. This case is back in 2018. We're going to launch the poll and would love our attendees. We have a total now of almost 75 attendees. Would love to hear from you. What would you do? Surgery, chemotherapy, followed by surgery, chemoradio, long course, short course radiation, or total neoadjuvant treatment. So I'd love to hear from all of you, if possible. Okay. So we have around 70% answers from around 75 participants. For the sake of time, I'm going to end the poll and share the results. And the first question for Dr. Safar. Dr. Safar, young patient, low-lying T2 mucinous adenocarcinoma. How would you approach such case at Johns Hopkins back in 2018?
Yeah, thank you. Can you hear me?
Yes.
Okay. Thank you for the question. So at Hopkins, over the last few years, we have changed our approach quite significantly. So 2018, we were doing probably the same as what we're doing now, but some alterations. A T2 tumor, really, I'd normally counsel the patient that they'll need a resection with no concerning lymph nodes. And in this gentleman who it's very close to the muscle, I'm a little bit concerned about the radial margin. And based on your MRI that you showed me, I am concerned about the radial margin, you know, in the same sort of logic. So I know T2 is not clear indication for radiation, but we would discuss radiation. You know, we would discuss radiation. At Hopkins, we've been given radiation as 5x5. We have over the years gone to total neoadjuvant therapy now. So we give 5 days and then 2 weeks later we start FOLFOX. And initially in that time we were giving 2 months of FOLFOX. Now we give the full chemo up front, even though there's no lymph nodes, even though there is no metastasis. So do we need to? I think it might be a case where you're over-treating if you give radiation. There's no doubt that there is complications that come with the radiation if you give it. My concern is you take them to the operating room and then your margin is less than 5 millimeters. And then you ask yourself, should I have radiated? Radiating post-operatively, in my opinion, is always much worse than radiating pre-op. It really hurts your anastomosis. In terms of connection, I think you have enough space to connect. So I think it's a low anterior resection. So you either go to surgery right away or you radiate.
Okay, Isa, with this concept of radiation as an important, let's say, thing in this low-lying young male with maybe a threatened margin.
Yeah, as mentioned by Dr. Safar, he's worried about radial margin. And here is the question of radiation therapy. And from literature, Osama, we know that long course chemoradiation therapy, and with high dose radiation up to 54 gray with 6 cycles instead of 5 cycles of chemotherapy increases the incidence of complete response, and most likely your patient will be most probably will be benefit from wait and see. And regarding short course, there is a data recently published from UK in 54 cases. So they tried 5 fractions times 5, and after good responders without complete response, they underwent a transanal resection, not ABR. And the responders, the patients with complete clinical response, they observed them. So you have these options after short versus concurrent chemo radiation with the old technique.
Shauki, do you think the mucinous component of the pathology would have changed your decision managing such case?
To tell you the truth, Osama, with the T2, no. Basically, in such case, if I have a good rectal surgeon who knows how to do endoscopic ultrasound, I would like to confirm that this is actually a T2 and not anymore. If I can confirm it with endoscopic ultrasound, I would take this guy to surgery. I would not expose him to radiation, because I have no evidence that radiation therapy plays a role in T2. Now, he may tend to, he may end up to being T3 pathologically. That's a fact, but then I will be radiating everyone who is T2, fearing that they might be T3.
Dr. Safar, do you think there is still a role for endoscopic ultrasound in such cases with the high quality MRI that we have?
So here's the problem with the ultrasound. The ultrasound is operator dependent. The more you do, the better you get at it. We have gone away from it so much that I myself I'm not very experienced at it anymore, because we've gone to MRI almost exclusively. And even our endoscopic colleagues, the GI colleagues, yes, they do it. But because, again, we don't do it very often, I'm not sure it would add. But I agree to the extent that T1, T2 is probably better with the ultrasound. But because the lack of experience, I feel it's become less of a valuable tool.
Okay, Ahmed Araqat, how would you approach this patient?
Yes, actually, it's very interesting discussion from Dr. Safar Isa and Dr. Shauki. I would agree maybe with Dr. Shauki. We would go with end-to-end ultrasound. I know that it's operator dependent, but unfortunately, the MRI has not been developed, or the protocols has not been developed properly, like by Dr. Gina Brown in Royal Marsden Hospital, where they have progressed far away in MRI of the rectal tumors. I would go with, because you said it's T2, I would be a little bit skeptical about T2 in this case. I would be looking more that it's approaching the sphincter muscles, the elevators. So I would do end-to-end ultrasound. I would look how much far the tumor from the elevators, and I will approach properly accordingly. If it's close, less than 2 millimeters from the muscle, I would do the radiotherapy. Okay. I would go with surgery.
So giving his young age, the risk that he might lose his sphincter, giving it's a low-lying tumor, and there's, low-lying rectal, maybe it's different than high rectal tumor, we elected to go actually, and he's so reluctant that he might end up having an APR or problem with the sphincter. We elected up to proceed with that total neoadjuvant therapy approach. At that time, we used induction for 4 cycles of FOLFOX, followed by long course chemoradiation, 45 gray. And this is the MRI after the treatment. You can see there's still, the lesions are still there. The relation to the external, to the levator venae had not changed. The hyperintensity, T2 hyperintensity still is there, involving most of the rectal wall. And you can see these are still lesions and in very close proximity to the levator venae muscle. And you can see it's almost, the reading was nothing had changed. There is no response at all. That's how they read it, the radiologist. Little to no response after chemotherapy as well as chemoradiation therapy. So the question is for the group, how long would you wait before taking this patient to surgery? And we're going to start the poll now. How long would you wait before taking this patient to surgery? Because we know next is surgery. 6 to 8 weeks, 8 to 12 weeks, 10 to 12 weeks, all of the above is okay. Shadid, can you comment on the total neoadjuvant in low-lying rectal young male?
Yeah, so it is actually controversial, Osama. I mean, T1, T2, distal, trying to, preserve organ. This is a topic is controversial. You go with neoadjuvant or surgery up front. I think I would personally consider it, given his young age and trying to, improve his surgery outcome. I would consider it, understanding this is a controversial, and it's not a standard of care, but I would definitely consider it for the patient.
Okay, thanks, Shadi. So again, we have 99 participants, and we now going to touch on the topic of how much you can wait or timing of surgery after such treatment. So the majority had chosen, هي تقريبا 46% had chosen 6 to 8 weeks. Dr. Bashar, do you think the time different for how long you should wait, and is there an optimal duration after long course chemoradiation? And we'll touch on after short course later.
So just so I understand, Osama, you said that he got 2 months of chemo, then got 5 weeks of radiation, and then no more chemo after the radiation.
Yes, no more chemo.
Okay, so you're basically asking from the end of the long course, how long do you wait?
Yes.
Yeah, I would say, there's a little bit of controversy, because if you talk to the watchful wait advocates, they would say to you, if you wait longer, you might get more response, including complete response, out to 3 months, maybe even longer. So they would say, I would rescope this, including our own sort of in the US, Memorial Sloan Kettering would probably say this. Now, your MRI has shown almost no response.
Yes.
Not just a little bit of response, almost none. And you've given chemo 2 months worth, and you've given radiation. So I think you've gotten it as good as it's going to get. The concept of waiting after radiation is to allow the lesion to respond more and more and get shrinkage and get, a little bit sort of favorable surgical margin. So I think whether it's 6 to 8 or 8 to 10, it's reasonable. I probably would go with 8 to 10 more so than 6 to 8. I think 6 weeks is a little too early, in my opinion, but I think there's been a bunch of data looking at the optimal timing after the long course, but this is not exactly applicable to this scenario where they've gone with chemo for 2 months and then they've done. So these are, it's almost like the Wild West. There's so many variations of delivering these therapies these days in the rectal cancer world that it's hard to interpret exactly each scenario separately. The way I see it is, if you've given a good amount of chemo, you have to give radiation a little bit more time to work than 6 weeks. Whether it's 8 to 10 or 10 to 12, I think you're splitting hairs.
Okay, does the timing of surgery different from a short course or long course, Dr. Safar?
For us, it's big difference. So traditionally, as you guys know, short course was given in the big trials that were done in Europe, like the Swedish trial, and it was done really based on convenience. The Swedish population all live far away from these big centers, so they went to this center to get their radiation. So they gave 5 days and then they went back home, and they operated right away. You got 5 days of radiation, then you got surgery. And as the time has evolved, we have now moved to 5 days of radiation, then we give chemo. And whether you give chemo for 2 months or 3 months or 4 months, you end up having to give the patient some time to recover from the chemo, which is at least a month. So the minimum we've operated after the short course is 3 months. That's based on our experience. And that, we believe, allows you to get complete response and as much downsizing and as much downstaging as possible. Back to Osama's point, he made a point earlier about the UK. We've probably got about 60 patients in our database now, Osama, and our complete response is close to 40% with 5 days of radiation, 5 times 5, 5 grays times 5, and then 3 months plus of chemo, 3 months plus. It's been varied because we've changed our target. So I think that the wait is much longer after the 5x5, much longer.
Okay, so you're talking about the Rapido trial, is that right? That's what you're trying to
That
distinguish?
we've been doing essentially the Rapido protocol for a long time.
Okay.
We've been doing the Rapido protocol at Hopkins for about 4 or 5 years.
Okay. Isak, can
but we were not given as much chemo. Sorry to interrupt. We were not given as much chemo. We changed to 9 cycles after the Rapido was published.
Okay.
Or just about that time.
Okay, Isa, what do you do, guys, at King Hussein Cancer Center? Are you guys adopting the Rapido?
Yeah, sure. Last time we gave long course chemoradiation was 2.5 years ago. So we moved completely to total neoadjuvant approach. We use the short course 5 grade times 5, followed by either FOLFOX or K-box 6 to 9 cycles. Then we evaluate if the patient achieved complete response. We wait and see with wait and see management versus surgery. So we are happy with the short course with total neoadjuvant, and pathological CR is really promising. It's up to 37% in our study that we conducted 2 years ago.
Okay, Shauqi, did you guys switch to the Rapido since the publication of it, or are you still doing the standard long course chemoradiation?
Yes, we did, only in those patients who are eligible. So remember, the Rapido included patients who have high risk. So somebody with a T3 and 0 who has no extramural vein invasion, those patients still get the long course with concurrent chemotherapy. But those who have high risk features, yes, we have switched to the Rapido protocol.
Ahmed?
Actually, I was listening to you, and I was thinking that it would be nice that if you could add anyone from our radiation oncologists at King Hussein Medical City, because I think we still do the traditional way, which is the long course. We haven't changed. We try to discuss with them, but I think they still stuck to the.
This video is on Facebook, and it'll be there for the next week, and then we'll be going to our YouTube channel. So if they're interested, you can share it with us.
I am very keen to let them know about it. Yes.
Okay. So the next question for the attendees: what type of surgery would you attempt on this patient? T2, maybe very low lying, close to the levator ani, no lymph node with no response to chemo, transanal excision, abdominoperineal excision, or ultra low resection with coloanal anastomosis. And at the same poll, we'll have another question: would you attempt this open or laparoscopic? And we're gonna share the poll with you in a second. Okay, so the poll is active. Would love to answer, if you can answer the two questions. We have 100 attendees with us, and would love to hear from you. What kind of surgery? Transanal APR or ultra low resection, and would you attempt this open or laparoscopic? Remember, young male, 32-year-old, mucinous adenocarcinoma that is low lying. So you have two questions for this. Okay, so we have around almost 103 attendees. Would love to hear from all of you if possible. And we have around 70% answers. So we're going to end the poll and share the results. So majority, 61% had chosen ultra low with coloanal anastomosis, and 62% would attempt to do this laparoscopic. Dr. Safar, how would you approach such thing in your practice?
Yeah, I mean, I have to say I agree with the response. We would offer ultra low anterior resection with coloanal anastomosis, we're sort of lucky enough that we have a lot of robots, so we would do it robotically. I think the robot has really enhanced the pelvic dissection portion of minimally invasive surgery. It doesn't really have to apply to every colorectal operation, no, but really for the pelvis, it makes a difference. So despite all the data that shows the lack of non-inferiority, if you like, but I think robotic really offers great vision and good retraction in all of it.
Okay.
So
What do you think about the transanal TME that is now trying, some people talking about it, and the risks in such condition in this patient?
yeah, I mean, that's a good question. No, this is really my own bias, my own opinion. This is not based on data. I tried this technique a few times and I found it pretty difficult. You know, we're trained to look at the pelvis from above and pretty familiar with the anatomy this way. Trying to look at it from below was a little bit difficult. So I think you have to do a lot of that technique to get good at it. It's not the same as the other, you know, regular pelvic dissection. And it's only applicable to the low tumors. You know, the high tumors you can go from above, and, you know, because that way you're taking out the whole rectum anyway, and you need to take out the whole rectum. So how many low tumors go to every center every year? It's not that many. And when you spread it amongst a few surgeons, I don't know if people can gain the experience. So if you go to, for example, the people who really advocate it, they have one person who's doing it for a large referral center. So that's my bias. I don't believe that it's as good, or at least as the outcome is equivalent to the robotic surgery from above. You know?
Ahmed, what do you think about what would you do for this patient?
Yeah, actually, it's a very interesting question. Now, if I am 100% sure that there is no invading or close proximity to the elevators, I would go with ultra-low. We have actually good experience with ultra-low resection. We're doing now laparoscopic. We can take part of the internal sphincters. We can take part, all of it, up to the dentate line, up to anal verge. So yes, I will go with ultra-low, but if I'm 100% sure that there is no invasion to the elevators or the external sphincters.
So this is some videos from the surgery. I started my approach through the pelvic component, and I could see that the tumor actually is maybe have extension by feeling below the dentate line. So, and you could feel like it's still really stuck to the external sphincter. You can, when you move it, the external sphincter is moving. So, giving the mucinous component, the no response, the aggressive nature, we elected to proceed with APR. So I proceed with APR, and basically, this is what we have done for this patient. This is the specimen, and Dr. Safar, what do you think about the quality of the specimen from the look that you have?
Sorry. I think the computer is a little bit behind. You have more views of it? You have another?
No, actually, no.
Okay. It looks good. It looks good to me. I mean, it looks intact.
So what do you think
but
about,
you know,
the
way now that the sort of the American College of Surgeons, sort of this quality program that they're sort of asking everybody to be a part of, we've applied, we're getting our accreditation soon, is they ask you to do 3 pictures and upload it to the system. So a posterior, a right lateral, a left lateral, just to see if there's any big defects in the actual specimen.
Okay. So the interesting thing about the pathology, that basically this patient had complete response with no residual tumor, and only mucin was seen about in his specimen. There were no tumor, and it just all radiation changes and 16 lymph nodes. None of them had actually therapy effect. So what do you think, Shawqi, about this pathology in this young patient with this imaging? You are muted, Shawqi, muted.
To start with, I probably disagree with the pathologist. Since there is no tumor, I think it will be T0 and 0 rather than TX. Okay. Having no residual tumor, I definitely would not give the patient any adjuvant therapy.
Okay. Dr. Safar, had you had such a case where the imaging had said there's no, no response, and this is what kind of pathology ended up with?
Yeah, that's have we had? Yes, we have. Our radiologist is getting better and better. There are no Gina Brown, as you guys mentioned. We are getting more focused on this problem. What we do and what I do is I scope these patients, and I typically scope them a month after they finish their chemo. And if I see just a scar, clean scar, as we heard some of the participants discuss, and it's a complete clinical response, based on the scar, I question the MRI. Not too much, but I question the MRI. I tell you, in my experience, and we've had a fair number of these, this scar tells you the story more than the MRI. MRI can be misleading. Now, if Gina Brown is reading it, maybe that's different. But I think for the rest of the world, doing an endoscopy after you finish the chemoradiation is important.
Okay. Shadi, would you give this patient adjuvant treatment after this pathology, or you would just observation? And this is also the question for the attendees. Go ahead, Shadi.
T1, T2, usually we don't, do systemic therapy. And this patient, because of distal tumor, got chemotherapy, got chemoradiation, he has complete response. I will, just stop with the surgery at this time. I will not do more chemo for.
Great, and this is what most of our attendees had answered, and we're going to stop sharing, and we're going to go to the next case. Next case. 1 second. Thank you very much. Okay. Go open. Ismail Khalil. Okay. Ensure. Okay. So we're going to go for the next case. In the meantime, we'll take some questions. Shawqi, do you think that total neoadjuvant approach for such patient was an over-treatment?
Yes, would I have given him total neoadjuvant treatment? No, of course not. I already mentioned that. But whether was this for that person an over-treatment, I cannot tell, because I cannot tell what was his actual tumor, if you have done surgery on him. So I don't know if I made myself clear.
Isa, and we don't have a radiologist with us, but do you think that response for mucinous type is actually more difficult to assess by MRI?
Yeah, definitely it's more difficult to assess an MRI, but probably you can ask the radiologist to do more sequence of MRI, like image diffusion or any biomarkers that probably will help in defining a clinical response. Plus the clinical exam, plus the endoscopy, and probably this patient, over-treated, in my opinion, because totally neoadjuvant protocols did not include early stage rectal cancer. So if you look at the literature, you only find chemoradiation in most protocols, and Haber-Gamma defined this very well, and clinical CR is very high with chemoradiation alone. And if you want to increase your clinical CR, as I mentioned before, you need to give 54 gray with 6 cycles instead of 5 cycles weekly chemotherapy. And regarding the short course, as I mentioned before, it's published recently in the UK study. So the pathological CR, so more than half of the patients achieved complete clinical response after short course neoadjuvant radiotherapy.
Okay, we'll go to the next case. 72-year-old male presented blood per rectum with perineal pain. Colonoscopy had shown a low-lying rectal tumor, 3.5 centimeters from the anal verge. And you can see this is the tumor, an ugly-looking ulcer, very low. And he has also a polyp in the sigmoid that was tuberculous adenoma with high-grade dysplasia. His CA19-9 is normal. And this is his MRI. This is the sagittal view. You'll see an aggressive-looking tumor in the distal rectum with almost attachment to the external sphincter, rated as T3 with some local regional lymph nodes, as you can see in this images here. So they're rated as T3 N1, and you can see the circumferential margin is threatened. He had a liver MRI that showed two liver lesions, one in the basically dome of the liver close to the left hepatic vein, another one in also segment 3, as you can see here. So this is a locally advanced PET scan, again, confirmed local advanced rectal with two liver lesions, no other signs of metastasis. So this is a metastatic, low-lying rectal, locally advanced, and basically with liver metastasis. So how would you approach such patient? For the attendees, refer for surgery, for primary, or refer surgery for liver, or systemic chemotherapy, or FOLFOX-based chemoradiation, given the local advancement nature of the disease in his rectum, or just a 5-FU-based chemoradiation. Can you please answer? This is a metastatic rectal with, say, limited metastatic disease. And we have 100 attendees. Would love to hear from all of you if possible. Okay, for the sake of time, we have around 60 answers. So we're gonna end and share this. So the majority, 60% had chosen C, which is systemic chemotherapy. Okay, great. Shawqi, you're happy?
No.
Why?
Okay, so first of all, this guy has to be discussed in an NDT.
Yes.
And of course, unfortunately, I don't see we have, but you're probably a liver surgeon too, so you might help us.
Yes.
What I have seen from the quick pictures that you've showed us is the liver lesions are small. And I don't like to give chemotherapy for small liver lesions because they disappear. Unfortunately, not all the surgeons will go and take that involved segment out. So if that patient is not very much symptomatic from his local disease, I know he has rectal bleeding, I would actually ask the surgeon, if possible, to go and take the liver lesions. And then I will give him short course of radiation and follow it up with systemic chemotherapy. The chemotherapy I'll give him for 12 cycles, not for 2 cycles, because he will need adjuvant chemotherapy for the liver lesions. Or it could be less than 12 cycles, and I will finish it by 12 cycles after surgery.
Okay, the idea of disappearing liver metastasis, that is a kind of a hot topic. I agree with you. It would make our life difficult to find these lesions with systemic chemotherapy. But I think with this metasynchronous presentation, I think we're talking about bad biology. If you ended up doing liver resections and for some reason patient get a complication, then basically you will delay his main treatment, a systemic treatment, for maybe another 2 to 3 months. And I think that would really affect his outcome. From my standpoint, Shadi, what do you agree? Do you agree with Shawqi going liver first?
Yeah, no, I think the way I approach this, this is a patient who has locally advanced rectal cancer. He has 2 liver lesions, and you said Osama was a PET scan, right?
Yes.
Well, yeah. So we have a limited metastasis, the way I approach it is chemotherapy. I will start first with chemotherapy. He's 72, FOLFOX chemotherapy. He will handle that well, and I will, follow him during this time, and then consider, of course, you need a liver surgeon input about, these resection.
They are easily resected.
Then chemoradiation and resection for the rectum and the liver, either sequentially or at the same time if possible. We need the input of the rectal surgeon, liver surgeon together. I mean, some of these liver lesions, the synchronous metastasis, they actually can do well, and they can have a long-term disease-free survival.
Okay.
And at the same time, when you do this, you can test the biology, as you said. Some of these are aggressive and they can show lung metastasis another way, and you can save them, surgeries and other more aggressive therapy.
Dr. Safar, how would you approach such a patient in Hopkins?
Yeah, point well taken about the disappearing liver met. We have liver surgeons. I don't do liver surgery. I think the liver, so like such small liver lesion can disappear if it's very well, we would go after the liver. Let's just put it this way. Even when it disappears, we'll go after the scar. I think sometimes I put fiducials where they would just put some marks so they can find it with an ultrasound at the time of surgery. But in general, we would start with the Rapido protocol, which is what I said. 5 days of radiation and FOLFOX.
Okay.
Nine cycles.
Okay, great. So for those who choosing to go with chemotherapy first, this patient is KRAS mutant, NRAS wild type, BRAF wild type. What type of chemotherapy would you choose? Basically, can you please answer? Just 1 second. You go with FOLFOX only, or would you go with FOLFOX plus anti-VEGF, or FOLFOX plus anti-EGFR, or FOLFIRI plus anti-VEGF, or FOLFIRI plus anti-EGFR, or FOLFIRINOX, triplet, or FOLFOXIRI, whatever. So would you, what type of chemotherapy would you choose for this patient? For the medical students with us, if there is, or surgery residents, we look at the KRAS to decide whether this patient would respond to anti-EGFR or not. If he has a wild type KRAS, then we can use the anti-EGFR. If not, then we cannot. So this patient is mutant, so we cannot use anti-EGFR. So let's see what are the answers. So we're gonna end the poll, and around 30% used FOLFOX plus anti-VEGF. What do you think, Shawqi, if you're gonna choose something for this patient? I know you wanted to go with surgery liver first approach. What kind of chemotherapy would you choose for this patient?
Okay, so definitely I wouldn't use FOLFIRINOX because that will make his liver lesions go away very quickly. So that's definitely against my principle. I'm not that big of a fan of bevacizumab in the first-line setting, especially in patients with a possible resection. So I would definitely go with either with only FOLFOX without bevacizumab. Anti-EGFR has no role in patients with KRAS mutant, so I wouldn't use anti-EGFR.
Shadi?
I will do 4 months of FOLFOX, Osama. I will not use Avastin, agree.
Interesting. And why is that?
I think the aim here is we are, going to do surgery and, practically like, getting Avastin for a short period of time, and then you're going to hold it for 6 weeks and all this. And again, it's not, there is many of these options can be done. The practical of using Avastin, and it's minimal, increased benefit with that. So that's why I'll just go with FOLFOX.
Okay. So the patient received actually 6 cycles of FOLFOX plus anti-VEGF, giving his systemic presentation, systemic synchronous presentation, aggressive local disease, and basically presence of metastasis. The doctor, so how would you reassess the response in this case, giving his liver as well as local disease? Let's ask our attendees to help us with how would you assess response in this patient, metastatic setup. Would you do liver and pelvic MRI, PET scan, CT with IV contrast, colonoscopy, or all of the above? So we have around 60 answers. So we're asking to end it up. So the majority had chosen all of the above. Dr. Safar, how would you reassess this patient? You're muted, Dr. Safar.
Sorry.
Yeah.
Definitely definitely get a liver and a pelvic MRI to see what it looks like now. We don't usually use too many PET scans in the assessment of response. If you were not sure in the beginning whether these were Mets or not, that's fair enough. And not necessarily colonoscopy. We do a flexible sigmoidoscopy, very limited assessment of that mass, because you had a very nice video showing it to us in the beginning. So I would use a combination of an endoscopic assessment, FlexSig, and MRIs of the liver and the.
Okay. So this is what he had was basically he had a PET scan that showed complete metabolic response in his liver with the disappearance of his liver lesions, also an MRI, and significant reduction in his metabolic activity in the rectal tumor with local regional lymph nodes. So we have a disappearing liver metastasis, as Dr. Shouqi was concerned about, and we have a significant, basically, response in his primary tumor. What would you do now in terms of basically management in this patient? Would you refer him to surgery, basically, for the primary resection, provided that he did not receive any local regional treatment for his tumor, or maybe refer him for liver resection, or continue same chemotherapy, or maybe use 5-FU-based chemoradiation or FOLFOX-based chemoradiation, or short course chemoradiotherapy. Dr. Shouqi, what's your experience in the use of FOLFOX-based chemoradiation? You are muted, Shouqi.
Apologies. I probably used it only once in my lifetime, but really there's no benefit. I mean, this has been tried, PTAC-6 trial, no increase in the pathological response rate. I know that I think the idea of using it in case you have systemic disease, and that's basically it. So the short answer is I don't use it.
Okay. Dr. Safar, what would you do for such patient after he had an excellent response in his liver, but still an active disease in his primary with systemic chemotherapy only?
How much chemo did we give him?
He had 6 cycles of FOLFOX
6 cycles
plus bevacizumab.
Okay, so to be honest, I think we would probably give five days. One of the advantages of the 5 days, you can slide it in the middle of, let's say, a 12 cycle or a longer cycle of chemotherapy, and you get the benefit of the radiation. I think there is no doubt that the radiation adds to just having chemo, but again, we'll find out. There's a few trials going on, but I think at Hopkins we would give him radiation at this point, 5 days, and give him more chemo, not for necessarily systemic, but trying to get them as much response out of the pelvis. Now, if the pelvis is resectable at this point, you could say, well, we've given 6 cycles. Is it time to go to surgery? We would still radiate.
Okay. So Isa, this is a question for you as a radiation. Do you think really in rectal cancer, radiation is really important, or we can avoid radiation in certain group of patients? Is it important to all patients, or can we avoid it in certain group of patients with maybe response to systemic chemotherapy only?
So it's the patient that you shown has a circumferential positive margin. So after FOLFOX palliative chemotherapy, probably I would like to see the pelvic MRI to make sure that the circumferential margin is still positive or clear. So based on that, I will determine what's the next step is it short course radiation therapy in situation of a clear surgical margin, or if the circumferential margin is positive, probably I will go for long course chemoradiation therapy. In some situation, you can omit radiation therapy if you are planning for organ preservation approach. So we have some percentage of patients achieve the clinical response. So responders more than 20%, you can, you can observe them.
Okay.
And the prospective trial, one of the arms in it, it's omission of radiation therapy after FOLFOX chemotherapy.
That's my question for you, Safar. Where are we at from the prospect trial? Are we done, or are you guys participating in this? Are you trying maybe to selectively use the radiation in certain group of patients?
I'm pretty sure they've closed enrollment, but we don't, and we're not. We were active participants when it was going, but now we haven't put anybody in the prospect trial. And I'm pretty sure it's closed, and we're waiting for the data. And I agree, one of the arms will tell us more about this. Interestingly enough, in general, in the United States at least, we over radiate in general. I think there's a lot of Mercury trial, and in the UK, the circumferential margin is not red, which is not this patient. You can forego radiation, but so that's why my bias was to give radiation. But I agree also, get an MRI and see where you are.
Okay. So this is what he happened. He received 5-FU-based long-course chemoradiotherapy. And again, this patient was totally against the idea of losing, with the chance of his losing his rectum or his anal canal. So basically, was totally refusing the idea of surgery. So the oncologist went ahead with an aggressive total neoadjuvant approach, more 5-FU-based long-course chemoradiotherapy, and 6 cycles of FOLFOX. And this is what happened after he's done. There's a complete response in his rectum, small rectal ulcer, biopsy is gone. This is an actual image from him. And the CT scan, complete metabolic and morphologic resolution of both his rectum and his liver lesions. So we have a complete response in both with this totally adjuvant aggressive full course chemotherapy followed by full course, long course chemoradiation therapy with complete response in both in his rectum and in his liver. So what would you do? And his 72-year-old totally against the chance that he might lose his rectum. So what would you do? Watch and wait, prepare for surgery, for liver, for primary, or continue systemic chemotherapy? So Ahmed, what do you think? What would you do for this patient?
Yeah, actually, it's a very interesting question. I think I would discuss this with the patient, and this is the most important thing. I would give him all the options. I would tell him that you have a tumor, you have a malignancy in your rectum, you have malignancy in your liver, you had some radio chemotherapy, and all disappeared. We are not 100% sure that all disappeared, but what the imaging shows, and they are not 100% accurate, yes. I would discuss with the patient. Another thing that this 72-year-old, is he, how comorbidities does he have?
Zero. Performance is zero.
Healthy, is he
Excellent performance.
fit? I would discuss with the patient. I would discuss what trials are going around about watch and wait, and leave it to him.
Dr. Safar, what do you think?
Yeah, for sure. I would discuss watch and wait. We have a few people who are, but what confuses me is the liver. I don't know what to make of it. Yes, it went away with chemo. Yes, there's no PET avidity, but I feel, at least from your story, that the radiation had as much of a hand in the complete response as the chemo did in this tumor. The liver was not radiated, but it responded. So again, we would watch, but carefully. We have a lot of experience with watchful waiting for the rectum, and we know how to predict it. You know, when it comes back fairly predictably in the scar, and you don't lose too much, meaning your plan goes back to plan, you know, to sort of a resection. How to sort of manage the liver, it's a tough one. If you're going to go after one, you should really go after both. If you're going to leave one, should you leave both?
Okay, so this is what the patient and family chosen for watch and wait.
Good.
And the protocol that we did actually was for him colonoscopy and digital rectal examination every 3 months. And giving the whole PIT story with him, we used PIT scan every 3 months. And this is in October, around almost a year since after his finished his treatment, almost less than a year. Again, there's complete no active disease in his rectum, as you can see here. This is the rectum, as you can see. There's no lesions at all, no scars. And what we had seen in his PET scan, that the 2 liver lesions actually had appeared again. And we did an MRI for him, and you can see the 2 liver lesions. Barely you can see them. You can see one right there, and other one also in segment 3, basically, as you can see there. So this is again the MRI of the rectum, colonoscopy and MRI of the rectum, the complete disappearance of the lesion without any thickening or any evidence on recurrence in MRI. So now we have a complete response in the primary and we have systemic relapse. What would you do for this patient? Let's ask our attendees. Would you start systemic chemotherapy? Would you consider liver resection in this patient, or maybe SBRT for his liver, or maybe the supportive care? So we have a few more slides and we'll be in hopefully by the hour. So the majority had chosen refer for liver resection. Shawqi, what do you think?
Okay, so I need to go back and say that I would have actually referred him to an expert surgeon who would actually resect those areas with the liver, which were involved by the liver lesions, rather than waiting until they come back. Because we know that resecting liver lesions that are progressing, those patients don't do as well as when you resect them when they are in response. So, but at the present time, since if he comes to me and those lesions are up, yes, I would definitely resect them. I think the more important question is, what are you going to do after resection? Are you going to give him adjuvant
That's how the question is coming, Shawqi. Don't go.
or not?
Isa, what do you think the rule of SBRT for these liver lesions in such case?
Okay. So, Osama, first question, is the tumor resectable?
Yes. No, but again, Shawqi, for your question regarding his liver resection, this resection would need a left hepatectomy. Okay, so a relatively major resection, giving his, and then if you look at basically at the liver volumes, just from a liver surgeon standpoint, you will see his right lobe is relatively small. And if you are going to do a left lobectomy, you would have to preserve his middle hepatic vein because, again, right lobe is small. You had to preserve his middle hepatic vein. It would be a challenging resection, but it's resectable. In a patient, his performance is 0, they're resectable. So,
especially in the hands of good surgeons like you.
Thank you. Isa, what's the rule of
SBRT? Okay,
SBRT?
I would discuss this case with the surgeon. So I would like to hear his opinion about the resectability. And if the volumetry done, it would be great to assess the remaining hepatic reserve for after surgery to expect the complication from planned surgery. If the tumor is unresectable or this 72 years old man has some contraindication to surgery, I would offer stereotactic radiotherapy to these 2 lesions.
Okay. So what we've done is, again, we did the liver resection, and this is just a quick video of his surgery.
This is the left, this is the right gastric, and this is the right portal.
This is the left portal vein. This is the main portal vein. Ready for the, but I think the trick is to preserve his middle hepatic vein, as you can see here. So we're preserving his middle hepatic vein to make sure he's getting enough outflow in his liver. I think this is very important, giving his relatively small right lobe. So, and basically this is we did the resection on the, and these are the lesions based after getting the specimen out. So this is 2 nodules completely excised, and we go back to a Shawqi question. What would you do for this patient? Shadi, what would you do for this patient? And would love to hear from our attendees. Would you observe him? Would you give him more chemo? Or would you refer him for primary resection?
Osama, what is the duration between, when he had finished the chemo and when did these nodules come back? Like 1 year? What did you say?
Almost 7 months, 8 months.
8 months, yeah. I think there is really no right or wrong answer here. I mean, this is like a stage 4 with no evidence of disease now after resection. So these tumors are out now. And I think I will think about it. It's like, this is someone who has synchronous metastasis, and it is actually synchronous metastasis. And they just showed up in 7 months and resect them, and I will just watch him observation with no chemo. I mean, if there are a new cancer, a new disease, I probably will think about it differently.
So Shawqi, since you brought this issues, would you give him more chemo? Would you observe him, or would you maybe consider referring him to the colorectal surgeon for a primary section?
I think we've agreed that his primary will be watch and wait. So I would definitely want, especially that he's not interested in taking his rectum out. I would definitely discuss it with the patient. The evidence is not that strong, but I would definitely discuss, since those were actually coming up, they were progressing, I would discuss giving him 6 months of adjuvant FOLFOX.
Okay, that's what the patient had actually. And I would like to thank you again, Dr. Safar, Dr. Ahmad, Isa, Shadi, Shawqi. Thank you very much for being with us in this night. And if you have a last one final comment, Dr. Safar and our guests for the attendees.
Well, it's very much a pleasure to be with you, and really enjoyed this very complicated discussions, and very nice to meet you all, and it's a real pleasure. Hopefully, if you are anywhere near Baltimore, come and visit us. Well, we'd love to meet in person one day. Everything's gone to Zoom, so.
Yep. Hopefully, we'll have you in Jordan soon, Dr. Safar.
Inshallah.
Shawqi, one final comment.
Thank you, Osama, for bringing us together, and I'll be happy actually to participate in futures. I enjoyed it very much and also learned from it.
Thank you. Isa, one final comment.
Yeah, thank you for these two interesting cases. With this debatable discussion, interesting. I think we learned a lot, and the audience are happy with this meeting. So make it more frequent.
Inshallah. Shadi?
Osama, you have done really good job with presenting these cases. I really like the way, the video, everything. Interesting cases, challenging cases, and thank you for the opportunity.
Ahmed, one final comment.
Thank you very much, Osama, and well done for all these challenging cases and ground rounds, and thank you for the participants. Actually, I just want small comment for the attendees. It just accentuate the individual approach. You presented two cases, very interesting cases, different approaches, different management, just to accentuate the individual approach for rectal cancer management. Thank you.
Great. Thank you very much, guys. Good night, and we'll see you soon, inshallah. Assalamu alaikum.
Inshallah.
Thank you. Salam.
Thank you.